My name is Tammy Wymer, and I am here to present on effective leadership at the DNP level. Nursing leadership and retention is incredibly important, as DNP leaders are in a very unique position to modernize and lead in the healthcare field. Briefly, we'll touch on evidence-based practice, systems-level thinking, using our clinical foundation, policy skills, advocacy skills, and outcomes focus and organizational leadership, followed by retention, systems-level thinking, advocacy, and quality improvement. Leadership styles are really important because 88% of nurses correlate their leader with their job satisfaction. Specchia et al. Did a systematic review across several scholarly search engines, including CINAHL, PubMed, and Embase, to find 60 texts addressing the impact of leadership styles on their nursing staff. They found a strong relationship between leadership style and job satisfaction amongst nurses. We've all heard the expression, people don't leave jobs, they leave managers. Positive styles in descending order of positive responses are first, transformational, the most effective. These leaders have effective communication, charisma, they're inspiring, and they're really aware of the needs of each of their staff members. This is truly the goal of any effective leader. The next most effective is authentic leadership. I have a friend who is an authentic leader, and she is honest, direct, self-aware, and can be vulnerable with her staff, as long as it's the right topics. A resonant leader starts with heart. They have high emotional intelligence, strong trusting relationships, and are able to reflect on situations. A servant leader focuses on the growth of each individual, autonomy, coaching in the moment, and shared decision making. The negative styles, these are not in order, are laissez-faire. This leader is more hands-off, avoidant, and described as the absence of leadership at times. Passive avoidant is the style that I have unfortunately fallen into at times of burnout. This leader avoids conflict, tends to be more reactive than proactive, and this results in high turnover and low retention. The study found both positive and negative responses based on transactional leadership. The transactional leader is more task-focused, relying on extrinsic motivators rather than passion and engagement. Nurse leaders must be aware of their leadership style in order to take feedback and improve over time. We must be able to ensure competencies and outcomes are met, boost morale, and balance the needs of the organization with the patient. Employees. This is influenced mainly by the leadership style of the leader in the group. Leadership has been cited as the most impactful aspect of the job satisfaction. Corbett and et al. Reviewed qualitative answers from 1,300 military nurses regarding their level of job satisfaction related to their leader's style. They noted retention issues, post-COVID fatigue, and many left the profession or even retired early due to COVID. As of 2020, according to the World Health Organization, there was a shortage of about 5.9 million nurses in the U.S. If population were distributed equally, that would be 118,000 nurses per state. This makes it more difficult to engage staff due to higher workloads and long-term vacant positions, which results in lower retention, higher turnover. Information sharing was also a big topic. Staff reported if they don't receive information in an effective and timely manner, they felt more isolated, uninformed, or that their leadership wasn't present or engaged if there were communication barriers. A leader must understand the needs of their individuals. I've heard that 10 to 12 employees per manager or supervisor is the ideal number to keep costs controlled but also provide the right amount of support. Exact needs would vary based on department needs, educational style, and the frequency of unanticipated results. Think hospital nurse, who might come up with different things every day that needs leadership intervention, versus a utilization management nurse, who might do the same tasks repeatedly and have very few new or unanticipated situations that would need leadership involvement. Nurses are really wanting a more intellectually stimulating environment. This could be part of why some of us chose to pursue a DNP despite having no specific career goal to use with it, like myself. Leader engagement has been linked with increased nurse work-related, self-reported well-being. Leaders who are engaged are shown to lead teams of nurses who are holistically well compared to their disengaged leader counterparts. Some ways to increase empowerment might include shared governance, strengths-based leadership when assigning projects, individual education or CEU opportunities, discussions about career goals without judgment so staff feel comfortable sharing with you and you can support them, committee involvement, tuition reimbursement, conferences, and bringing back that information so they can be seen as a subject matter expert by their colleagues. Cohen also found that teams with an engaged leader perceived their workload to be lower and their environment to be more positive overall, even if the environments were very similar. One tool that is really powerful is the tight, loose, tight tool, and I'll show you an example. Tight is a really effective tool in highlighting the areas of a policy or procedure that staff might have influence over. So here's an oversimplified example, washing hands. The tight, the first one, is the goals and purpose. So for our example here, the organization has a guideline on hand washing before and after certain activities. So this is something that the staff don't really have any control over. In the middle is our loose. This is where hopefully 80% of the policy lies. This is where staff have ability to influence how they do the work. So they could sing a song in their head. They could use soap and water every time or use hand sanitizer every other time. They could use a certain brand or scent of soap, or how often do they put lotion on. The tight on the right-hand side are the non-negotiables. These are usually accountability or regulatory things, like infection prevention, safety, and patient satisfaction. These often include the whys behind the first tight. Burnout and turnover. So we've linked effective leadership with lower burnout and lower turnover rates. Here are some of the things that impact burnout and turnover. Burnout is often referred to as long-term occupational stress. Leadership has a lot of influence over burnout and turnover. Nadushin et al. Did a study of 319 nurses. About 900 were invited to participate, but only 300 returned their surveys. They found there were 3 major themes related to burnout, each with numerous contributing factors, which I've listed examples from the study and personal experience here. Higher nurse satisfaction is positively correlated with improved patient outcomes. Happy nurses, happy patients. The first category is environment. The schedule was talked about in a lot of these responses from the nurses. Night shift, alternating shifts, shifts that just don't work with their family. These could all be issues that would cause stress to an employee. Working conditions were also cited frequently. This was also something that was talked about by the union when they were trying to unionize at Group Health in Madison earlier this year. Working conditions were described as patient ratios, could include safety things. Availability of supplies was something we experienced during COVID that I think is also a safety issue. If nurses are overusing their supplies, like using a mask repeatedly until it's visibly soiled, this likely is going to contribute to burnout. Leadership styles we've addressed and how they impact burnout and turnover. And then psychosocial factors are the third category here. Social structure, interactions with peers. We've all heard the term nurses eat their young. How are we onboarding people? Are they getting a standardized and thorough socialization? Are we welcoming them warmly? Are we putting a sign on their desk saying, "Welcome, we're so happy to have you"? Or are we just moving on with our day and ignoring them? I saw this happen repeatedly at another clinic at my last job, and it was very clear which locations were really supporting onboarding socialization and which ones weren't. Stereotypes can also lead to undue burnout and turnover. If somebody feels that they are being biased against, or if they feel like they just don't fit in, they might be more likely to leave that position. Change management is something that leadership can definitely impact. Whether changes are brought to employees in a timely manner, if they're getting their questions answered, if they're getting follow-up, loop closure, if they're getting everything they need to really be successful in this change. Ethical and moral factors can have an impact as well. One example would be a nurse working on a transplant floor, but that nurse doesn't really have an ethical or moral agreement with maybe certain populations of people, prisoners, people with a history of alcohol use, getting a liver transplant. That would be something that would cause undue burnout or turnover stress on this employee because they're having these ethical issues. Perception of control is also a big deal. Employees need to feel that they have some level of control over the work that they do, and using that tight, loose, tight tool can be helpful in that situation. And then compassion fatigue and secondary traumatic stress was also brought up in several studies. Secondary traumatic stress, according to Nadushin, is a component of compassion fatigue, representing another significant consequence of prolonged exposure to others' trauma that is associated with sleep disturbances and other indicators of poor emotion coping. So nurses are experiencing this secondary trauma and stress because of what they're seeing every day. And this doesn't just include flight nurses or ER nurses or ICU nurses. This could really be anybody on any patient's care team. Understanding burnout. 62% of nurses are experiencing burnout as of 2025. 69% of nurses under 25 are experiencing burnout. So typically, these would be nurses in just the first 3 years of their career. 93% of nurses have cited increased stress during COVID-19. CPR is a group-based intervention that Charlo Swilly and their team implemented with both nurses and early childhood educators. They found that both of these populations had similar stress throughout COVID, similar issues, and thought they'd be a great populations to study burnout and do a quality improvement project. So CPR here stands for compassion, practice, relationships, and restoration. They really did a good job of educating the subjects on what stress, trauma, and emotional regulation are. So they had the words to describe what they were experiencing. They educated them on coping mechanisms, managing their emotional distress, practicing self-compassion, and professional well-being. It's really important here that they included the leadership as well, so they have that buy-in and that support from those that they report to. This was rooted in evidence-based practice, and the different practices that they taught the participants were referred to as micro-restorative practices. I really liked that. There are different small things that we can do throughout the day, like stepping away or naming an emotion or just saying, I'm okay with this, or I'm just going to move on. So these tiny things that they did throughout their days really showed promising results in decreased burnout, decreased occupational stress for both the nursing and early childhood educator populations. Ability and maturity. It's important that a leader is able to foster flexibility while still maintaining a certain level of maturity or accountability in the workplace. For flexibility, this really relies on the leadership style. A highly engaged leader who knows the needs of their organization, of their employees, and really can trust their staff might have more flexibility than someone who's more task-oriented and is just looking to check off things on their list for the day. For maturity, presence and awareness were frequently cited in the studies I looked at. A highly effective leader is present and aware. They know what the boundaries are of their staff, they know what the expectations are from their staff, but similarly, they've set boundaries and expectations for their staff. It's really important that if somebody exceeds those boundaries or doesn't meet up expectations, that the leader follows up immediately whenever feasible, often in private, to make sure that the expectations are clear and that accountability is held based on the organization's leadership, coaching, or progressive discipline path. It's really important that DNPs are here to advance the nursing profession. As we discussed before, we are leaders, we are educators, we are researchers. We're really the advocates for our staff and our patients. Advocacy was described by Sheehan as the capacity to participate knowingly in change. I thought that was a nice quote. Being the most trusted profession, 20 plus years per the Gallup polls, we only lost once to firefighters in 2001. Nurses are looked to by the community as people who they can trust, people who they can go to in a crisis, people who will always do the right thing. We talked about moral courage in class a few weeks ago, and I think this is really important. Nurses are trusted because we have moral courage. We will do the right thing, even if it's hard. Advocacy can be impacted by historic hierarchy. Providers have often been seen as more important or more worthy of respect in the workplace, just based on the history of nursing being a more female and direct care role. With nurses now serving as CNOs, CEOs, legislators, and leadership in general, RNs now have theory courses in holistic care, including community needs and family needs, and we're really able to look at the patient with a viewpoint that other professions can't. The nurse is at the bedside or in the clinic a lot more time than the provider is, and we often have the ability to do a more thorough assessment of the patient's holistic needs, like their family needs and community needs. The nurse spends a lot of time working with the social worker, making referrals, and talking with the patient. Education. The AACN does not support DNPs as educators as of 2006 due to a lack of teaching and learning theory in the DNP curriculum, unless a nurse educator track is taken. With this being a nursing executive leadership track, we really lack the teaching and learning theory courses to be effective educators, but that doesn't mean that there aren't nurse educators out there who don't have a background in nurse educator formal education. The DNP nurse educator receives additional education and background on subjects like pathophysiology, which we as DNP executive leaders may not have practiced in years. This refresher and background is really important for us to be able to give up-to-date, accurate information to our students. I would recommend, based on the AACN stance, that those of us wishing to go into education take some courses on teaching learning theory at a minimum. Nurse DNPs are also in research. Our curriculum is grounded in research. We studied how to evaluate a study, how to read a study. We took statistics in the MSN program so we could really understand what the results were saying, if it's clinically significant, if it's repeatable. The DNP does more implementation than the PhD nurse, but both are skilled in evaluating and performing research in an ethical manner. And as leaders that we grow a diverse workforce, so patients can see themselves in those who are caring for them, and so we're practicing in an ethical manner and making sure our patients have cultural competency from the staff who take care of them. This starts before the admissions office in nursing school. We have to consider the impacts of redlining. Back in Roosevelt's time, when it was legal to deny someone a housing loan based on the color of their skin or their sexuality. Unfortunately, these folks who were discriminated against ended up in food deserts or areas that just aren't given the education money that they need from the government to provide a really thorough, high quality education. If one school offers a chemistry class and a wet lab and all of these other things to their students, but maybe this other student didn't even have a textbook or they didn't have a chemistry lab, they're going to start their education already at a disadvantage just because of the community that they grew up in. Things like scholarships, tuition assistance, and loan forgiveness can help even the playing field, making it so that everybody has the ability to go to school if they are motivated and have a goal. Inclusive recruitment practices include interviews, not just essays. It's important that nursing leaders can meet the people who they're thinking about admitting to the program and make sure that they have a population of students that really reflects the community they're in. Mentorship programs, like the one that we're doing for our DNP, makes it so that nurses have an ability to go and see other leaders in the community. Maybe they can find someone who is really successful, who has a similar background, and learn from them. How did you get to this position? How can I get to that position? Cultural competency training is really important, both at work and in school. In my BSN program, we had an entire class just based on cultural competency. It's really important to have an open mind and be a continuous learner. We came up with situations at my previous job where there were people who were refugees from Iraq coming to our clinic, and we sat down and we talked about maybe some of these cultural considerations we'd have to think about. For example, some of that population, the female patients will only speak to a female interpreter for Pashto patients. And so that can present different barriers because only about 1 in 10 Pashto interpreters is female. This resulted in a lot of downstream effects, like these patients having to wait longer. We really had to put things in place to make sure that these patients were receiving the same care, the same level of care that other folks are receiving. It's important that we're aware of health disparities. Studies show that people are treated differently based on their gender, their color of their skin, their sexuality. It's important that we're aware of these biases, even if they're unconscious bias, and making sure that we're working to be anti-biased. Community outreach is important. There are options in the community to work with underserved populations. For example, I work with a flu clinic that goes to vulnerable areas where they are a food desert or they have lower incomes in that area. Maybe they're more prone to not having adequate health insurance or access to care. We go out and we make sure that these children receive their vaccines. We are positive influences. We bring coloring books and talk to them about, maybe you want to be a nurse someday and be a good role model. There's also inadequate representation in leadership roles. People of non-Caucasian backgrounds are biased against, and we can see this in studies. For example, Phillips and Malone found that the rate of diverse people in leadership can be up to 20% lower than the percentage in the community surrounding. The practices above can really help make sure that leaders get the same opportunities no matter what their background is. And finally, a culture of belonging. It's important that we welcome people warmly, our colleagues, our patients, other leaders. Make sure that we treat everybody the same, regardless of their role, regardless of the background, regardless of the color of their skin. We're leaders. People look up to us. We've come a long way since the days of Florence Nightingale. We're not just caregivers now. We're leaders in the healthcare community, highly trusted and respected, capable of great change, and we will continue to grow the profession through advocacy, research, and education. Thank you so much for listening, and I will play my references last.